In Liverpool, England in December 2016, a 7-month-old boy, Alfie Evans, was brought into a hospital with an undiagnosable degenerative neurological condition after suffering seizures. Eventually, Alfie's condition gradually worsened, leading to him being in a semi-vegetative state for more than a year. The Alder Children's Hospital, which Alfie was admitted to, said that brain scans showed catastrophic degradation to his brain tissue. The doctors also determined that further treatment to Alfie was not only futile, but also unkind and inhumane. Now, whilst the doctors said that nothing more could be done for Alfie and they wanted to withdraw treatment, his parents disagreed and they wanted permission to fly him to the Bambino Gesù Hospital in Rome. The hope was that they would potentially be able to prolong his life, because in the Italian hospital, which has links to the Vatican, suggested operations that would help Alfie breathe and keep him alive for an undefined period. His parents said they wanted to fly him to a hospital in Italy, but this decision was blocked by the Alder Hospital, which said continuing treatment was not in Alfie's best interests. So this issue was taken to court and a legal battle ensued between Alfie's parents and the Alder Hospital, where the court ultimately decided that the doctors could stop providing life support for Alfie against his parents' wishes, saying the child required peace, quiet and privacy. Now, unequivocally, Alfie Evans' condition was a tragedy, because to lose a child, especially at such a tender age, is something no parent should ever have to go through. Now, this case does bring about many questions with regards to consent, especially with regards to children. We will also be looking at child autonomy and how doctors look out for the best interests of a child patient. Further, this case of Alfie Evans that we've just discussed, we'll get back to it very shortly, but let's first discuss some important medical ethics terms and legal terms. Okay, so in the last video we talked about consent, informed consent, autonomy, and best interests. So these things have already been discussed. If you haven't gone through the first video, please check it out. There should be a link there, somewhere, I'm not sure. Okay, so if you watch that video, you'll have a very good understanding of these key terms. We will go through them once again in very brief detail, but I'd once again strongly encourage you to watch the first one if you haven't already. Okay. It's a common conception that a parent has absolute say over what happens to the child. For example, if your child is admitted to the hospital, a lot of people believe that as a parent you have absolute say over what treatment they get, what treatment they do not get. But this isn't always necessarily true, as we saw in the Alfie Evans' case. Now firstly, before we get to that, we need to talk about what confidentiality is. The doctor-patient relationship must clearly be based on trust. One of the cornerstones to trust is confidentiality. Patients must be able to trust their doctors to not disclose medical information about them, except to other clinicians and healthcare professionals who will need to be involved in their care and who are similarly bound by a duty of confidentiality. Now, breaching this sacred trust will undermine a patient's confidence in your practice, but also in the whole profession as a whole, or the NHS as a whole. Now, doctors have a duty to uphold professional values in their own conduct and be mindful that they are representatives of a profession. Poor individual conduct can impact the public's perception of the profession as a whole. Now let's now talk about best interests. We'll start with best interests with regards to 16-plus-year-olds, that's 16 and 17-year-olds. So what happens when a child aged 16 or 17 consults a doctor without their parents' permission? Well, this is quite a common thing, because when a child is 16 or 17, they're essentially a young adult. They are starting to become more independent. They start to take more control of their lives. They have more say in what happens to them. You know, the law also regards them as having the ability to consent towards treatment in their own right. Parental agreement is not always required in this case. In fact, it's actually never required. They can provide their own consent, and they can also have the right to Now let's talk about children under the age of 16. So children under the age of 16 may consult doctors or other healthcare professionals without their parents knowing and without their knowledge, and request that the detail of the consultation is kept from the parents. Now this is often, but not exclusively, when it comes to sexual health or mental health issues. Now the GMC says this: respecting patient confidentiality is an essential part of good care. This applies when the patient is a child or young person, as well as when the patient is an adult. Without the trust that confidentiality brings, patients and young people might not seek medical care and advice, or they might not tell you all the facts needed to provide good care. Now, this is controversial, as surely a parent has a right to information about their child's health, and while they have a legal duty of care for that child, they actually don't have the right to know information about their child's health, interestingly. And this nicely leads us onto the case of Mrs. Gillick. So, Mrs. Gillick was a lady who brought forward a case in 1982. She challenged the Department of Health ruling that a doctor could prescribe contraceptives to a girl under the age of 16 without her parents' knowledge. Because after all, parents have a duty to protect their child's moral and psychological well-being. And they have a right to raise their children in accordance with the belief that sex below the age of 16 is wrong and can be harmful. This was according to Ms. Gillick, and according to Ms. Gillick, parents have a right to know if their child below the age of 16 has consulted a doctor about contraception. Now, the court found against Mrs. Gillick. Their view was incorporated into GMC guidance is that a doctor's duty is to the patient also being a child. So a doctor may prescribe contraceptives or give advice on sexual health to someone under 16 and keep that information from the parents, so long as they believe to be in the patient's best interest and that the patient, the child, is competent to provide her own consent to the treatment. Now, of course, this was and still is for some people controversial for two reasons. Firstly, as we've already said, parents are normally the ones who provide consent for their children under the age of 16, but this landmark case established the concept of Gillick competence, named after the lady that brought forward this case. Now, Gillick competence gives a child under the age of 16 the legal authority to provide his or her own consent to any treatment. This is not exclusive to contraception. If he or she has the maturity and understanding to make the decision, they can provide consent. They have the right that information about the treatment is kept confidential. And secondly, this applies even if the treatment is contraception. However, in this instance, further safeguards apply, and these safeguards are known as Fraser Guidelines. So Fraser Guidelines are a thing that ensure child safeguarding, and they basically ensure that the young person understands all aspects of contraceptive advice or treatment and its implications. Now, when it comes to children, whatever degree of decision-making capacity a child possesses, it should be respected because they are patients at the end of the day. To summarize, once a child reaches the age of 16, he or she has the legal right to consent to treatment as per the Family Reform Act of 1969. If a child is younger than 16, they are entitled to consent in their own right if they are Gillick competent. Now let's talk about the assessment of capacity in children. Now, a child may be capable of making some decisions about their treatment, but not others. The ability required for different decisions will vary both in complexity, importance, and irreversibility of the decision. That was 3 things. The question is, are they capable of understanding the information relating to this decision and rationally assessing it? It's a question of whether or not the child has the mental capacity to understand the nature of the treatment, why it's been proposed, its risks, its side effects, possible outcomes, alternatives of the treatment, and what will happen if the treatment is not given. Now, as per the Children Act of 1989, children, unless they are very young, are capable of some level of understanding about how their illness and treatment, and will have preferences about how they are treated. Now, this is important to understand. This does not mean we follow their treatment preferences in all cases, because at the end of the day, well, they are still children, but rather it means that we should take into account the views of children when deciding what is best for them. Now, each child, like each adult, is an individual, and what is best for a child depends on their individual characteristics and circumstances. Let's now think back to the term Gillick competence. Why do we talk about competence rather than capacity in children? This is an important thing to think about. The simple answer is that there's a very important legal distinction to be made. Now, the ruling on the Gillick case stated that a child must have the maturity to make a decision and not simply be able to understand the nature of that treatment in order to be judged as competent. They must also be capable of making a reasonable assessment of the advantages and disadvantages of the treatment. So this again is controversial, because does this mean that they must reach the same decision as the doctor who is treating them? Now, what this effectively means, and this is controversial because any child who disagrees with their doctor would be judged to lack competence. Now, some may argue that this is objectionable completely, this is paternalistic, because this means that a child can only consent to the things that a doctor has already agreed with and that has already decided that. But on the flip side, surely, given a doctor's clinical and medical competence and understanding, it's appropriate for them to set a standard as to what a reasonable decision entails, because the doctor would best understand the advantages and disadvantages of a treatment and their recommendation for the treatment. Now again, it could be objected, understandably, that a doctor may be imposing their own personal judgments on the child when deciding what is best for the child. Now, if this were to happen to an adult, if a doctor was imposing their medical view on the adult, we would call that disrespect for autonomy. However, In the case of children, it's different because children may not fully understand what is right for them and what isn't. And so in many cases, a child's decision is overruled by the doctor. Now, this may be difficult to understand, and once again, it is controversial, but the main point is a child may have the maturity to make a decision and not simply understand the nature of the treatment in order to be judged as competent. So, by law, the right to consent to treatment is not also the right to refuse treatment, in the case of children and young people below the age of 18. Now, the law essentially states that you have the right to refuse treatment only when you reach 18. And essentially, this denies the right to those below the age of 18 in order to protect them from unwise choices. This means that a child under the age of 18 cannot refuse treatment. And yes, even for children aged 16 to 17 under the NHS, your refusal for treatment can be overturned by a court. Below the age of 16, any refusal to treatment by a child or young person has to be authorized by a parent or a legal guardian, even if that child is considered to be medically competent to consent. So in this case, parents assess whether a child's refusal is unwise and would cause them serious harm. But even if a parent upholds a child's refusal, that decision can be challenged in court. The treatment team believes that the refusal is clearly harmful to the child. For example, in the Alfie Evans' case, we saw how the parents' decision to take the child to Italy was overturned. And this nicely leads us on to parental involvement and the case of Alfie Evans that we're now revisiting. Now, doctors should not, and they legally cannot decide alone what is best for a child. They should consult and seek authorization for treatment from a person with legal responsibility for the child, a parent or legal guardian. Now, thus, doctors, they should ask parents to give their full authorization on behalf of their child. Parents are legally required to make a decision that is in the best interests of their child. Therefore, if a treatment team believes that the parents have refused treatment that is clearly in the child's best interest, or they're trying to push for treatment that is not in the child's best interest, they can challenge this decision in courts. Parental rights to decide for the child are not absolute. Parents are usually, but not always, the best judge of what is best for the child. Going to court should always be a last resort for doctors, because the best thing to do is try to persuade the patients to agree or disagree to treatment if they believe it's in the child's best interest, make them understand exactly why this treatment is important or why this treatment is futile for the child. Try to get the patients on board, because if you do something against their will, taking them to court and forcing them, compelling them that they cannot decide treatment for their child would upset them without a doubt. Now, we saw in the Alfie Evans case that the decision of the parents to try for more treatment was overruled. This happens very often in medicine, that a team of doctors believe that withdrawing treatment for a child patient is in their best interest. This is obviously very controversial and frankly sad for the parents, because as a parent, no matter what, you want your child to live. You'd want your child to be happy, no matter what the odds are of them surviving. Now, of course, a parent's desire to help their child obtain treatment successfully and help them get better stems from an obvious yet completely understandable bias. And it's for this reason, it's for this love, it's for this bias that if a parent refuses to give treatment or for the withdrawal of a treatment, this decision can be overruled by the courts if treatment is thought to be in the best interest of the child. Now, this is because sometimes, like we've seen in the case of Alfie Evans, keeping a child alive and putting them through extenuating treatment and more interventions, actively prolonging their pain and suffering, is of great detriment to them. It will hurt them more. Now, this decision unequivocally is not easy. It's sad. You cannot help everyone. And the fact is, sometimes it's better to remove or withdraw treatment rather than prolong a patient's suffering, especially a child's. For this reason, this decision is not made by a single doctor. The withdrawal and change in the course of treatment must be agreed upon by an entire team of medical professionals who try to decide what the best course of action would be, and if need be, the legal justice system also gets involved, and each ethical dilemma is investigated by the court on a case-by-case basis. Every case is different from the last one. Another important thing to know is, by law, healthcare professionals only need one person, one parent with parental responsibility to give consent for them to provide treatment or withdraw treatment. In cases where one parent disagrees with the treatment and one agrees, doctors are often unwilling to go against their wishes and will try to gain agreement by trying to talk to them or trying to talk them into it, essentially. Now, if an agreement about a particular treatment cannot be reached, in this case, a court can make a decision. Now, let's talk about emergencies. In an emergency where a child is on the brink of death, God forbid, where treatment is vital and waiting for parental consent would place the child at risk, treatment can be proceeded without consent, in the best interest of the child's safety. Okay, so now time for some leaving thoughts. Now, this was a lot of information. We discussed a few case studies, a few legal acts. Now, although this may feel slightly overwhelming, it's good to know, especially if you're preparing for a medical interview. If you're not preparing for a medical interview, these are still good things to know. Now, if you're preparing for a medical interview, I'd also highly encourage you to look at the case of Charlie Gard and Tafido Rakib. These are two very important cases, again to do with medical ethics and children. I would strongly encourage you to go through them. They may very well come up in your medical interview, and they're very good to talk about in an interview. Further, bye until then, I'll see you next week.